Hi, this is Dr. Poole from the Department of Pathology, and I'm going to talk about just some of the general clinical aspects of neoplasia. One thing that both benign and malignant neoplasms do is produce a variety of local effects. Location is a critical factor in determining the local effects of a tumor. For example, a small tumor in the pituitary gland, such as a benign adenoma, can produce big effects because if you remember where the pituitary gland is, it lies in a little bony depression called the sella turcica. And even a small tumor in this area can produce major clinical effects because of critical structures like the visual tracts that run adjacent to this area. In contrast, the retroperitoneum is an area that will allow for a considerable amount of expansile growth. So you can see really large benign and malignant tumors. In my example, I give malignant sarcoma, which can occur in the retroperitoneum. It can reach 20-30 centimeters in size and produce minimal or small local effects so that patients have vague or even no symptoms. So as I alluded to, neoplasms can produce compression or even invasion of surrounding tissues. And this may manifest in ulceration if this compression or invasion involves a mucosal surface accompanied by bleeding. If the compression or invasion interferes with blood supply, it can cause ischemic necrosis. If the tumor occurs in or around a hollow viscus like the large intestine or around a duct, it can produce obstruction and some of the local effects from that. Other local effects include decreased functional activity, such as in an endocrine gland. Insufficiency may occur because the tumor is destroying the gland. On the flip side, you can have increased functional activity. I'll talk a little bit more about that in the next slide, where you have increased deregulated hormone production by the endocrine tumor cells. Also, production of hormones or hormone-like products by non-endocrine tumors, which we call ectopic production of hormones, can produce paraneoplastic syndromes, and I'll talk about that in a few more slides. So just to reinforce the last point, neoplasms can have a variety of different hormonal effects. Certainly the easiest to understand are endocrine tumors, which produce hormones that are inherent to the organ in which the tumor arises. These are sometimes called functional tumors. These are actually more typical of benign tumors, since the acquisition of malignant properties by these tumors usually is associated with a loss of the functional capacity to produce hormones. An example is benign adrenocortical adenoma, which produces the hormone cortisol and causes Cushing syndrome. And as mentioned, non-endocrine tumors can sometimes produce hormones ectopically, meaning that the normally tissues that give rise to these non-endocrine tumors normally don't produce these hormones, but these tumors acquire the capacity to do so, or to produce hormone-like products that cause paraneoplastic syndromes. Cancer-related pain is a very important symptom that neoplasms, especially malignant neoplasms, can produce. Cancer pain affects more than 30% of patients who are undergoing active cancer therapy, and moderate to severe pain is unfortunately very common in patients during the later phases of their illness. And cancer-related pain may be nociceptive, neuropathic, or sympathetically maintained. And I know that you learned all about different types of pain in the brain and behavior block. Pain may be the result of direct tumor involvement by compression or invasion, such as invasion of bone, invasion or compression of adjacent neural structures. It can be produced by obstruction by vascular obstruction or invasion causing ischemia, and by mucous membrane ulceration or involvement. There are cancer-induced pain syndromes that may be associated with a paraneoplastic syndrome. There's pain that's associated with general debility that's related to advanced cancer. And then there's other types of cancer-related pain that are a little bit more difficult to identify the etiology, such as post-herpetic neuralgia. It's also important to remember that cancer-related pain may be due to stuff that we do to the patient for diagnostic or therapeutic purposes. So there are procedures that cause pain, such as bone marrow aspiration. There's the pain that's associated with postoperative recovery, such as after a mastectomy. There's pain that's related to the scarring that occurs after radiation that may involve injury to the plexus or spinal cord, or radiation-induced inflammation of the mucosal membranes or the gastrointestinal tract. And similarly, pain that's related to chemotherapy. Another generalized clinical feature of malignancy is cancer cachexia. This is progressive weight loss that's accompanied by profound weakness, anorexia, and anemia in patients with incurable treatment-refractory metastatic cancer. Interesting thing about cancer cachexia is its association with equal loss of both fat and lean muscle, an elevated basal metabolic rate, and evidence of systemic inflammation. And you can compare that with the situation with starvation, which is a biologically different process. So what's really being said is that cancer cachexia itself is a disease state as opposed to a readily reversible entity such as starvation. And some of the pathophysiologic mechanisms are distinctly different. So the changes in body composition in a cancer-laden state are different from those seen during starvation. And this is where we see patients with cancer losing both muscle mass and fat mass as opposed to starvation. Another difference is that patients with cancer manifest an increase, not a decrease, in their resting energy expenditure. It's counterintuitive that somebody is essentially in a metabolic losing state to actually increase their resting energy expenditure. And finally, cachexia from cancer is associated with a loss of appetite, not a gain of appetite because of hunger or starvation. And so people have been investigating what are the cellular processes that explain these clinical observations, and it's been suggested that cachexia is driven by inflammatory cytokines that are generated by the tumor, and these activate the ubiquitin proteasome system with subsequent muscle breakdown. Okay, I've mentioned paraneoplastic syndromes a couple times already, but these are disorders that are caused by cancer, but not a direct result of cancer invasion of the affected organ or tissue. So the tumor is producing distant effects, not by metastasis, but by hormones or hormone-like products that are produced by the tumor. They're actually fairly common, estimated to occur in 8 to 15% of cancer patients, and this is probably an underestimate just because of our difficulty in associating certain signs and symptoms with hormones or hormone-like products. So the spectrum of symptoms in paraneoplastic syndromes are largely secondary to the production of hormones, functionally active peptides, enzymes, growth factors, cytokines, and other substances that are secreted by tumor cells that are not normally programmed to secrete these specific protein compounds. So the tumor itself has acquired an aberrant capacity to produce these substances. Another mechanism is autoimmune immunological mechanisms, so the production of tumor-associated autoantibodies. And finally, the mechanisms of some paraneoplastic syndromes, frankly, are still poorly understood. You can look at paraneoplastic syndromes in a couple of different ways. You can classify them according to the different organ systems that are affected, but more commonly now they're classified according to etiological groups. So the four main ones are endocrine, neuromuscular, hematological, and cutaneous. And then, of course, there's another category for other. So please, please, please refer to the notes in the accompanying study guide, which includes a table of different paraneoplastic syndromes and the tumor types they're associated with. Another aspect of clinical neoplasia is the staging of tumors. Stage equals the extent of cancer at the time of diagnosis and is a way of defining prognosis that's a shorthand based upon the extent of cancer. And this is a critical element in determining the appropriate treatment options. What may be appropriate for a tumor that is localized may not be appropriate for a cancer that has metastasized. It's also useful for comparing outcomes between groups of previously diagnosed and or treated patients. And so it's an important parameter in the inclusion, exclusion, and stratification of patients when they're enrolled in clinical trials for a new therapy or a new intervention. In the United States, we stage tumors according to the tumor node metastasis staging system, which has been developed by the American Joint Committee on Cancer, the AJCC. So this is the so-called TNM staging system, where T is for tumor and incorporates the size and local extent or invasion of a primary tumor. N is the lymph node staging. So the number of lymph nodes that are involved and or the site of the lymph node groups that are involved. And finally, M obviously is for metastasis. That is whether the tumor has now involved distant organs or sites. Although it may not seem obvious, the genetic and molecular aspects of neoplasia are now part of the clinical aspects as well, because we incorporate genetic and molecular data about malignant neoplasms for diagnostic, therapeutic, as well as prognostic purposes. So we may look at a genetic or look for a specific genetic mutation or translocation or expression of a certain protein for diagnostic purposes because it's characteristic of a particular neoplasm. Similarly, these aspects can be used for therapeutic purposes if that protein can be targeted by a specific drug. Now these types of genetic mutations or expression of certain proteins may not be specific to a particular tumor, but as Dr. Bradrick will point out, it doesn't matter because they're targetable by a certain drug. And finally, we can use these aspects for prognostic purposes, meaning that we can compare groups of patients that may have a similar tumor type and a similar tumor stage, but the expression of one of these mutations or protein may provide information regarding patient outcome compared to patients with similar tumors that don't express or have these features. So those are some of the clinical aspects of neoplasia, and I hope you take these general principles forward as we learn about tumors from specific organs. Thanks.